Today I'll be speaking on advances in pediatric neurologic tumor imaging. We'll begin with discussing some clinical updates and providing a review of the 2021 WHO molecular classifications updates as it pertains to pediatric patients. I know that this isn't new. It's been a couple of years, but I think it's important to have a refresher to really understand why advanced imaging techniques are helping us in these pediatric patient populations. Then we'll go through some of the imaging techniques specific to pediatric patients and some of the advanced imaging techniques that we'll use. And then we'll kind of go through some examples of these different tumor families and discuss some advances in each of these categories. So what are our goals in pediatric neuro-oncologic imaging? First and foremost, we're diagnosing and determining the extent of disease. And can we take our imaging further? So can we guide treatment planning with things like fMRI and characterize tumor types based on molecular diagnosis? So can we use advanced imaging like DTI, spectroscopy, perfusion, and radiomics to really help us beyond what our conventional images can provide for us. So let's begin with the 2021 WHO updates. So we all know that there's a greater emphasis on molecular diagnosis in these updates, a change from Roman numerals to Arabic in terms of grading. And then with regard to categories of gliomas and glioneuronal tumors in the pediatric population, we see that the adult type gliomas and the pediatric gliomas were actually separated into separate tumor families. So we have the pediatric type diffuse low-grade gliomas, diffuse high-grade gliomas, circumscribed astrocytic tumors, and then categories with glioneuronal tumors and ependymomas. So under the pediatric diffuse low-grade glioma category, you're going to have finding tumors such as diffuse astrocytoma with MYB or MYB1 altered, and then also this MAPK pathway altered tumors. You can see that each of these categories includes the molecular subtypes of tumors. What we refer to as a pilocytic astrocytoma is in this circumscribed astrocytic glioma category. And then the pediatric diffuse high-grade gliomas are also broken down by molecular subtypes. And you have diffuse midline glioma, which was previously known as the DIPG, which is H3K27 altered, as well as the hemispheric gliomas and infantile type hemispheric gliomas. Additional update was the ependymomas are now classified by location with molecular subgrouping. So here you can see these are the tumors in the ependymal category, and you can see that they're separated by location. So supratentorial, posterior fossa, spinal, and then also with their molecular types. So this is ZFTA fusion positive versus YAP1, and we'll talk about some of the differences with these later on in this talk. Finally, there's subgroups of medulloblastomas that are included and new embryonal tumors. So if we look at those categories, you can see that there are 3 new embryonal tumors that were added with cribriform neuroepithelial tumor, CNS neuroblastoma, and CNS tumor with B-core internal tandem duplication C. And then the medulloblastomas are also broken down based on molecular subtype. So we'll move on to the imaging techniques. In the adult literature, we have the RANO criteria, and I wanted to draw everyone's attention to the RAPNO criteria, which is a review of imaging recommendations for response assessment in pediatric neuro-oncology. And so this was a group of papers predominantly focusing on the tumors that I've listed here, where they actually took a consensus between radiologists, neuro-oncologists, surgeons, and they kind of work together to define imaging guidelines, treatment response criteria, timing of repeat scans, and measurement guidelines. And the reason that this is important is really to try to standardize practice across institutions. So if we standardize our imaging and our sequences that are required, I think that in terms of future research and radiomics, this would be helpful. So for example, this is just a table that I pulled from the medulloblastoma and leptomeningeal seeding tumors, just to show an example. You can see that under the category of brain, they list the different sequences and then spine as well. So for example, something that is recommended is this SAG KISS Fiesta to look for drop metastases. So something to keep in mind when you're designing protocols for these pediatric patients. The other thing you want to keep in mind with pediatric patients is going to be the length of the scan time. So these patients are getting scanned usually every 3 months, depending on the tumor type, 3 to 6 months. And, if we can try to avoid sedation as much as possible in pediatric patients, that's our goal. How can we speed up image acquisition? So some ways are going to be radio case-based sampling, compressed sensing, AI acceleration of scan times. Synthetic MRI is a new entity where you can actually take a 5-minute scan and then generate T1, T2, FLAIR, and SWI images. So hopefully down the pipeline, that would be something that would be helpful in imaging these patients. And then hybrid scan protocols such as PET MRI, so the patient doesn't have to get 2 separate sequences. And you can see here, this is just an example of a case where we acquired a sagittal T1 space at 6.5 minutes. And then you can compare the quality of that to a CAIPI T1 space, which reduces aliasing artifacts in parallel imaging. You can see the image quality isn't much difference, but the difference in scan time is 2.5 minutes. And so if we can reduce the length of each sequence in these tumor protocols, it can be really helpful to increase patient compliance with the scan. So with our advanced imaging techniques, when we're evaluating tumors, we want to look at diffusion-weighted imaging. That's going to tell you the degree of cellularity. Diffusion tensor imaging, pre-op white matter tracks, fMRI, eloquent areas of the brain. I won't speak too much about the white matter tracks or the fMRI in this talk, given the time limit. Perfusion imaging will give you a sense of the angiogenesis of the tumor. And then spectroscopy will give you metabolic characteristics. And we'll talk about some of the spectroscopy results with these tumors. ASL perfusion, I wanted to touch upon because I think it's probably used more often in pediatrics than in the adult population. So it's a way to magnetically label spins of water protons to act as an endogenous tracer. And the benefits in the pediatric patient population is that so there's no contrast required, and you can actually use a smaller gauge IV gauge when you're giving contrast because the DCE and contrast enhanced perfusions usually require a power injector, and so that will require a larger IV gauge. And it avoids leakage correction in these cases that have breakdown of the blood-brain barrier. There's a lot more research, I think, that has to be done with perfusion imaging in brain tumors as compared to adults. In adults, I think that the research and evidence is much more robust. But studies have shown promise for sensitivity and specificity of ASL as compared to DSE or DCE techniques. Diffusion-weighted imaging is often applied to pediatric tumors to assess ADC maps and aid in classification of tumor type and grade. So can we decide whether it's a highly cellular tumor for something like a low-grade tumor with a BRAF mutation? Can it help us predict the type and grade? And then can we predict treatment response as well? MR spectroscopy. So there are different metabolites. We're commonly used to thinking about choline to NAA ratio for tumor grading, with a higher choline to NAA ratio shown to correlate with higher grade tumors. In the sort of adolescent population, this 2-hydroxyglutarate spectroscopy, which you actually can see here. There's a peak at 2-hydroxyglutarate that can be used to predict IDH mutant gliomas. And then there's molecular subtyping of tumors in the diffuse midline gliomas, which we'll talk about a little bit later. And if we're talking about advances in pediatric non-oncologic imaging, radiomics is really becoming more robustly studied in this patient population. So basically, the idea would be to determine tumor type, have a better molecular classifications of tumors preoperatively, and also try to figure out if we can predict prognosis based upon data that's been extracted from MRI. So the steps in radiomics is really going to be data acquisition. The images are then pre-processed, segmented. The tumors are segmented. There's feature extraction, and then you build a model based upon what you've extracted. and then you test that model against a cohort to assess performance evaluation. And we'll see different examples of how this has been applied to specific tumors. So now let's go through a couple of different examples of tumor families and tumor types and discuss what advances we've had recently with pediatric tumors. So we'll start with the circumscribed astrocytic tumors. This is a 3-year-old male with vomiting. You're reading this in the emergency department. You can see that there's an expansile lesion with T2 hyperintensity involving the medulla, and then there's heterogeneous enhancement. When we look at the diffusion characteristics, it's not really restricting diffusion. So you're thinking this is like a low-grade glioma on the brainstem, but can we take it further? And so this is where advanced imaging comes in and the molecular profiling. So many of these low-grade tumors, pilocytic astrocytomas and gangliogliomas, have mutations, either BRAF V600E mutation from wild type or BRAF fusion mutations. And so can we predict, based on MRI features, whether or not these BRAF mutations exist? The reason this is important is because BRAF fusions have better prognosis than BRAF V600E mutations. And so a lot has been done with diffusion in this area. So you can see here, this is a paper from Neuroradiology in 2020, which showed that the mutant type pilocytic astrocytomas and gangliogliomas had an overall lower ADC mean as compared to the wild type tumors in these categories. Interestingly, the BRAF mutated tumors also had a higher number of cystic components. Here's another paper kind of showing something similar. They compared V600E mutant tumors versus the BRAF fusion KIAA tumors, and then NF-driven tumors. And again, you can see that the BRAF V600E mutant tumors had lower ADC and more cystic components compared to the NF group. So ADC histograms have been applied to multiple of these low-grade gliomas to try to assess whether or not we have this BRAF V600E mutation and predict prognosis. On the flip side of it, we can identify, if we can have ADC identify tumor subgroups, but can we predict and sort of analyze how patients respond to particular treatments? So this was actually a cohort of patients with low-grade glioma that were treated with selumetinib, and they followed these patients, a group of these patients, over time, over the course of 2 years, and looked at the ADC histograms as it changed over time. And you can see actually transiently within the first 6 months, the ADC values actually increased. The idea or the thought process behind that was that as you start to begin to treat these tumors, there can be some edema. And then as the tumor sort of contracts and compacts down, the ADC begins to fall again. And so the ADC total actually decreased more during the course of treatment for responders compared with non-responders. And then if we apply radiomics to these low-grade tumors, can we differentiate BRAF mutated and BRAF fused tumors? So they actually, in this cohort of patients, trained and validated radiomic features based on FLAIR images. And what they found, basically, the model was able to predict with an area under the curve of 0.85. And interestingly, actually, the age, which is an older pediatric patient population, and the location supratentorially versus infratentorially are actually strongly predictive of BRAF V600E mutation. So let's see what's up with the pediatric type diffuse low-grade gliomas. So this was a 7-year-old male with diplopia and vomiting. And so you can see we have this expansile T2 hyperintense lesion within the posterior fossa. It's bright on the T2, but not completely suppressing on FLAIR. Many of you know this as this T2 FLAIR mismatch sign that has been more often described in the adult population with IDH mutant tumors. But in the pediatric population, this has actually been shown to be more associated with MYB altered brainstem glioma, diffuse low-grade brainstem gliomas. And that's important because these MYB altered gliomas actually have a more favorable prognosis. So here you can see again that those areas of T2 hyperintensity are actually suppressing on FLAIR. So moving on to the pediatric diffuse high-grade gliomas. This was a 10-year-old female who presented with diplopia and headache. You can see here the typical appearance of an expansile mass within the pons, engulfing that basilar artery. There is an area of central necrosis with ring enhancement and reduced diffusivity. This is compatible with diffuse midline glioma, previously DIPG. So there are a bunch of molecular subtypes or histone mutations associated with these DIPGs, and similar to the low-grade gliomas, can we try to predict who is going to respond better to treatment? So there are a number of studies looking at these high-grade pediatric gliomas. This was one that came out of Boston Children's from one of my colleagues, where they reviewed 83 patients with high-grade pontine gliomas, and they tried to differentiate imaging characteristics based on histone mutations. So these three mutations, 3A, 3C2, 3, and wild type. And what they found is that they could predict survival based on certain imaging characteristics, with H3, 3A histone mutations actually having poorer survival. So you can see that that curve drops off. And the lower survival was actually associated with enhancing tumors more often. So this is actually a radiomics paper for pediatric diffuse intrinsic pontine glioma. And again, you can see there is a expansile lesions in the pons here. These are two separate patients. What I thought was interesting about this paper is that in the radiomic extraction of radiologic features here, something that they described was that when you have these T2 sort of areas that are a little bit more hypointense, interspersed within areas of the expansile tumor, these patients actually tended to have a longer overall survival than patients that had more focal areas of T2 prolongation within the pons themselves. And when combining the radiographic or radionomic features with clinical features and testing it against their testing data set, they actually had improved results. So combining radiomic features with clinical features. And then if we want to touch on a little bit on spectroscopy being applied to these tumors, there have been a couple of studies looking at spectroscopy in these high-grade gliomas, and they actually show that in addition to evaluating the choline, NAA, and creatine peaks, that these patients actually have the H3K27 mutant patients, were actually the higher grade, worst prognosis patients, actually have an elevated citrate compared to the wild type control. You can see the red line here versus blue. And so that's related to changes in glycolysis in those patients. Here's a 16-year-old female with vision changes, and just to bring it back to an example of how we use spectroscopy at the workstation. So here's a lesion that was in the right parietal lobe with cortical and subcortical expansion and T2 prolongation. If we put a voxel on that area, you can see actually there's elevated choline to NAA ratio, which is concerning for a high-grade tumor. This patient actually had radiation, resection, and then was developing this T2 prolongation that extends from the ventricular margin to the subcortical white matter. And so the question is this going to be a recurrence, or is this post-operative change? And if we put a spectroscopy on a voxel on that area of FLAIR signal hyperintensity, you can see similar spectroscopy peaks compared to the preoperative examination. So there's an elevated choline to NAA ratio concerning for recurrence tumor that was pathologically proven. And just another example, here's a 9-year-old with hemispheric high-grade glioma. This patient had radiation therapy of a glioma that was in the right thalamus. You can see that post-radiation, there's these extensive FLAIR T2 hyperintense changes involving the insular and parietal white matter. Unfortunately, within 2 months, the patient's brain MRI looked like this, where you have this expansile T2 signal in the dorsal thalamus extending along the white matter and within the basal ganglia on the right. I think that just looking at these T2 weighted images, you'd be more suspicious for tumor recurrence than any post-operative change or post-radiation changes. However, we do have the ASL here, an example of this is a PASL. And you can see that there's increased perfusion within the thalamic portions of the tumors, and then also putting a spectroscopy voxel on there, that there's elevated creatine to NA ratio, so this is concerning for tumor. As opposed to an example of radiation necrosis, where you have this peripheral enhancing lesion in the left middle cerebral peduncle of someone that had radiation in this field. And you can see that there's an elevated lipid lactate, but not elevated choline or creatine. So this was favored to be radiation necrosis and resolved. Let's touch upon the embryonal tumors. Medulloblastoma was one of the tumors that kind of was was characterized molecularly early on by imaging. And so there are 4 subgroups of medulloblastoma. Wingless, these are typically located in your middle cerebellar peduncle, so as this one. SHH, which is more described in the cerebellar hemispheres. And then group 3 and group 4, which are midline tumors. Group 3 and group 4 have higher propensity for dissemination. And the other thing is that group 4, I think, tend to enhance less than group 3 is the description. And it's important to recognize these features because the prognosis is different. So wingless generally have the best prognosis, whereas group 3 and group 4 have the worst prognosis. And radiogenomics has been applied to pediatric neuroblastoma. This was a multi-institutional study from 12 pediatric centers where they used machine learning, and they were actually able to identify the 4 subgroups of medulloblastoma with 88% accuracy. So this was an example of a couple of their tumors. So this is another patient came in with 5-year-old with altered mental status, a posterior fossa mixed cystic and solid tumor. You're reading this and looking at this lesion. Could this be a medulloblastoma? Could it be a pilocytic astrocytoma, given that there's a cyst in this more like nodular area of enhancement? But when you look at the spectroscopy, you can see that there's elevated choline and that there's no NAA here. So that's going to tell you that there's going to be a medulloblastoma, no glial cells. This patient actually had a recurrence where you can see that there's nodularity at the recurrent at the resection site. And again, there's an elevated choline to NA ratio with biopsy proven confirmed recurrent disease at that site. So let's move on to ependymomas. This was an 8-year-old female with headache and vomiting. Again, we have a posterior fossa mass. This is from a recent call that I had. Patient comes in through the emergency department. You can see that there's this mixed heterogeneous mass in the 4th ventricle. Importantly, I think it's always important to look at the diffusion imaging first. So you can see actually in the 4th ventricle here, for something like a medulloblastoma, which is something you would consider in the differential here, you'd expect that there would be more reduced diffusivity, darker in ADC. The alternate thing that you would consider is an ependymoma. In this particular case, that's what I favored, given there was some small foci of hemorrhage as well within the tumor. There is this paper that's from a colleague of mine in the AJNR that actually I think is really useful when you're trying to evaluate posterior fossa tumors. So you want to classify it based on where in the cerebellum or brainstem it is. But then the next thing you really want to do is look at the diffusion weighted images. So if it has a low ADC, you're going to be thinking something more like an ATRT or a medulloblastoma. ATRT specifically also if the patient is less than 2 years of age. And then if it has a higher ADC, you're going to be thinking of things like pilocytic astrocytoma or ependymoma, especially if it has cystic or hemorrhagic calcifications, or calcifications within the tumor itself. So that's something to keep in mind. And there has been a meta-analysis of ADC values in pediatric medulloblastoma, ependymoma, and pilocytic astrocytoma. And you can see actually that the mean ADC value for medulloblastoma is lower than for ependymoma and for pilocytic astrocytoma as well. So important to look at your diffusion weight images when you see these pediatric posterior fossa tumors. And then, of course, in these ependymomas, can we predict the subtypes of ependymomas? So this was we had mentioned earlier in the WHO grading or classification of tumors that there are different tumor subtypes of the posterior fossa ependymomas A and B. The reason that this is important, again, is that PFA has a lower overall survival of 48% versus PFB of 98%. And so this was a radiomics paper where they extracted data on T1 and T2 weighted images from 157 ependymoma patients. And they found that the PFA tumors were actually more heterogeneous on contrast and enhanced MRI examination. And then expansile tumors demonstrated decreased overall survival. And similar to the high-grade tumors that we had looked at, if you look at spectroscopy studies in these childhood ependymomas, comparing PFA and PFB, the PFA tumors, which again are the more aggressive tumors, actually also have a higher citrate and exhibit elevated glycolysis as compared to the PFB ependymomas. Here's an example of a 17-year-old female with headache and seizure. This is an expansile tumor within the supratentorial compartment here. You can see that there is diffusion restriction, heterogeneous enhancement. The differential for this is going to include a supratentorial ependymoma, or you can include other high-grade tumors as well. This was a CFTA fused supratentorial ependymoma. And I just wanted to show this example for a couple of reasons. So this patient actually had tumor recurrence. You can see here there's nodularity at the tumor resection site. When you get a lesion like this and you give a differential, again, there's studies showing radiomics. Can we predict supratentorial embryonal tumors, high-grade gliomas and ependymomas, which would be in the differential for these? So this paper using radiomics was able to identify the difference between these three types of tumor. But I wanted to show another example of ASL imaging that we use. So that patient, again, had radiation therapy. That nodularity was increasing over time, but the ASL imaging didn't show any increased perfusion. So this was favored to be radiation change. I'll briefly just touch upon PET MRI. There was one study actually that showed that there's diagnostic accuracy and clinical impact by using a combined PET MRI. So they actually found that it changed clinical management in 8% of cases when they used combined PET MRI in patients with pediatric tumors. You can see this top image here. This is a kid that had a medulloblastoma resected. There was increasing enhancement. You can see that there's an area of reduced diffusivity as well. And this had elevated PET avidity. So this was called recurrence. Whereas in the lower panel here, this patient had some enhancement without really elevated signal. So this was thought to be post-radiation change, and the patient was followed. So PET MRI can also help to increase the specificity and accuracy of diagnosis. Finally, there's something a little bit more down the pipeline here is MR elastography, which has been studied, and the thinking here is that there's an inverse correlation between tumor grade and stiffness. So, and it's been shown that some IDH wild type tumors might have lower stiffness than the mutant tumors, and this might be helpful in sort of surgical navigation for preoperative planning. So in summary, I think that knowledge of the 2021 WHO classification is important to understanding the tumor categories and tumor molecular subtypes. Keep RAPNO guidelines and fast imaging techniques in mind when you're imaging these pediatric patients. Advanced techniques can aid in differentiating tumor types. And, understanding of pediatric brain tumors is rapidly evolving and expanding, so there's a lot of work to be done. And I look forward to learning more about this and within the next years. Thank you so much.